Yeah, this is your first case. Adult male, no history available.
Okay, so this is a frontal radiograph of an adult male. I can see that the right hemithorax is reduced, and I can see that there is a lobulated soft tissue opacity, which is seen encasing the right lung. It's larger on the right the right mediastinum. There are also small patchy opacities within the lungs. I cannot see any pleural effusion. There is no significant shift of the mediastinum or trachea. The left hilum is clear. The left lung field is also clear. The left costophrenic angle is normal. I can't see any bony lesion. So my impression here is that of a pleural-based mass or a right mediastinal mass, pleural-based mass. So encasing the lungs, I'm thinking most likely pleural mesothelioma. It may also be anterior mediastinal mass, which is with that pleural infiltration, such as invasive thymoma. I would review the previous images if available and check for history of occupational exposure to asbestosis, although I cannot see any pleural plaques to suggest that, and then ask for a chest CT to confirm my finding and refer afterwards to the relevant
What makes you
MDT.
think this is an anterior mediastinal mass?
Um, because my topmost is the fact that it's most likely a pleural-based mass, but
No, that
it
is
may
okay,
also be
but still, if you have to think about anterior mediastinal mass, that you have kept your second differential. So this mediastinal
yeah,
mass that you're looking at, why do you think it is
yeah
anterior?
because there's obliteration of the superior cardiac border, right superior cardiac border, and I can see that pleural vessels are extending through the mass.
So what is the name of that sign?
Hyder overlay sign.
Okay, good. So what will you do next?
Review the previous radiographs if available, check for occupational history of occupational exposure, and then ask for chest CT with
Okay,
intravenous contrast enhancement. Yeah.
this is your CT.
Okay, so this I've been presented with, is it a scrollable image or spots image?
You can ask for control.
Okay.
Yeah, go on.
Okay, so I've been presented with
Just click on
I've
the
been
screen
presented
once. Yeah.
Okay, so I've been presented with an axial intravenous contrast enhanced computed tomogram of the chest of the previously seen patient. This is in mediastinal window, so I'm scrolling through. I'll just scroll through from top to bottom and organize my thoughts before coming to give my findings. Okay, so from the images, I can see that the mass, this image confirms an anterior mediastinal mass with an invasive anterior mediastinal mass, which is seen to have pleural seedings in the right pleural and encasing the lungs. It's also seen to, sorry, I would pause on the mediastinum, the region of interest. It's also seen to infiltrate the pericardium, and as I can see some pericardial thickening, especially in the right anterior aspects of the heart. I can also see,
Any pericardial nodules?
yes, there are pericardial nodules, and I can
Can
also
you
see
show
that it's
me?
encasing. Okay, this, I don't know if you can see my arrow.
I can see your arrow, but go a little bit
Okay,
down.
this and this and this.
Go down. Little more.
Okay, yes, there's another one here.
Yeah.
Okay, so and I can also see that it's encasing, it appears to be encasing the it's invading the superior vena cava. There's a thrombus within the superior vena cava and also encasement of the right pulmonary vein. I would love to see
Are you sure it is invading
along.
SVC and not compressing it?
Okay. Okay, this is the SVC here.
Yeah. Yeah.
Yeah, I think it's compressing the SVC, but there's a thrombus within the is extending into. There's
But this is
compressing
just
the
part.
SVC and
This is
compressing
just
the
partial.
the
This is just
pulmonary
partial
vein.
volume. Yeah. This is just partial volume, partial averaging, nothing else. Okay. So your final diagnosis and management.
My final diagnosis is that it's an invasive thymoma with pleural seedings into the right pleural. So this is most likely a stage 4. I would inform the referring clinician and fast track the referral of this patient to oncology MDT for further management. Patients should also have an urgent abdominopelvic CT. I think it was already done alongside this imaging. So I would review the abdominopelvic CT to for complete staging of this patient.
Okay, if I
I would
tell you
also
that,
review this image in the bone window and soft tissue window to assess for bony metastasis and lung nodules.
okay, if I tell you that the coronal is important in this case, why is it so? Why is the
The
coronal
coroner is
important?
it's important because it's needed to check for extension into the I think it's needed
Into
to
what?
check for extension to compression of the IVC and also to check for if there's enlargement of the superior neck vessels. As I can see, there's already compression of the superior vena cava. So this is most likely causing a superior vena cava obstruction syndrome.
Okay, so coronal is important in invasive thymoma and in malignant mesothelioma to check for involvement of diaphragm and to check for subphrenic spread. Okay.
Okay.
Okay, so if we talk about thymoma, can you think of any disease associated with it?
Yes, it can be associated with myasthenia gravis.
Yeah,
It can
very
also be
good.
associated with pure red cell hypoglobulinemia and
Yeah, good, good. Okay, good, great. Okay, you did great. And we'll move on to the next candidate now. Candidate 1, are you there? Candidate 1.
Yes, I'm here.
Okay. This is your case.
Yes, sir, I'm here.
No history available.
All right. A radiograph and projection of a skeletal image jaw patient. There are heterogeneous areas of consolidation with internal air bronchogram in right upper and mid zone, which are reaching from the hilum towards the periphery. The lung volumes are symmetrical. Some patchy areas of similar density and attenuation are seen in the left upper and mid zone as well. There is mediastinal whitening predominantly in the aortic and above the tracheal region. This soft tissue density predominantly in the right paratracheal region is making an obtuse angle with the lung margins. However, there is no associated mass effect on the bronchi. There is mild deviation of the trachea, which is not clinically significant on the radiographic images. The rest of the aortic margin, descending aorta, and heart are normal. While I'm looking at the heart, I can appreciate that there's a retrocardiac opacity of the similar density as of the right paratracheal region. The superior aspect of the trachea are identified. whereas the background the background vertebrae are normal, the hemidiaphragms and the surrounding bones are normal as well. So this appears to be um, an infiltrate. It could be an infective etiology in the lung with with lymphadenopathy.
Like what?
Other possibility.
Infection like what?
I don't see any fingering love appearance, so it doesn't look like aspergilloma. Upper lobe unilateral involvement is more seen in the tuberculosis.
Okay.
And
Any other diagnosis besides tuberculosis?
the right paratracheal and bilateral hilar lymphadenopathy is also identified in the sarcoidosis. So other less likely differential could be sarcoidosis.
Good.
Further,
So if we think this is sarcoidosis, what stage it is?
it is the involvement of the parenchyma and the lymph node, so it will be stage 3.
Are you sure?
Stage 2. Both
How
are
many stages are
lymphadenopathy.
there?
4 stages. In the first
Are
one,
you sure?
there is
4 or 5?
5.
Okay. So just tell me what the stages are.
In the first one, there is only a lymphadenopathy. In the second, it's the lung and the
First is the
lymphadenopathy.
0.
So, okay, fine, thank you.
Okay.
First is the
So
0.
yeah, first is 0. Now you got it. Okay. So what is the next investigation
One
if
is
you have to? What is the next investigation here?
all right. So, comparison with the prior imaging is recommended.
Yes.
Following this, just and ACE inhibitors needs to be evaluated for final diagnosis and pulmonary
ACE
MGD
inhibitors? Or,
ACE levels.
yeah. And along with ACE levels, any other blood test?
Calcium levels.
Yes. And how will you confirm the diagnosis?
The diagnosis is usually confirmed through these blood tests and the HRCT findings. However,
Suppose
at
the blood
times
tests are negative, then
the biopsy needs to be done.
how will be the biopsy done?
In the lymphadenopathy, they can access through the endobronchial approach.
Yes, endobronchial ultrasound, guided biopsy. And what will be the biopsy show?
Granulomatous cells, non-caseating granulomatous cells.
Non-caseating granulomas. Okay, good. Do you know of any extrapulmonary findings of sarcoidosis?
So it is its manifestation is multisystemic. There could be
Yes.
manifestation bones where particularly in the hands appearing like a lace-like opacities. At times there is Loeffler, which is Loeffler is also the lung.
What's Lofgren syndrome?
In Loeffler syndrome, there are fleeting opacities in the lung, which is it's a kind of a consolidation, which are fleeting in the lung in the different zones and lobes, depending upon the flare up.
Okay, what about the eyes and skin and cardiac and neuro?
So there
Okay. Do you know have any signs on X-ray related to sarcoidosis?
the right paratracheal and bilateral lymphadenopathy.
Just name the sign.
It's a triple. I don't know. I can't recall
1, 2,
the
3
name.
sign.
Yes, it's a 1, 2,
What
3
about
sign.
Garland triad?
It's the same as
Yes.
the right
Okay.
paratracheal.
And on which investigation do you see the lambda sign?
That is on the nucleus study.
Yeah. Okay, good. And what is the galaxy sign?
That I do not know of.
Okay. So confluent nodules, they make the center, and small nodules are surrounded by small nodules that looks like a galaxy. and it is called galaxy sign because of the confluence of the nodules. Okay, what is the distribution of nodules in sarcoidosis? Just look
The
at the
mid
CT
zone
scan and tell me.
in the
No,
middle
I'm
zone.
no, I'm not talking about mid zone, upper zone. Which kind of
Okay.
distribution the nodules show?
Yeah.
Like, are they centrilobular or something else?
So it is a diffuse distribution in the
Just
peribronchial.
look at the CT scan and tell me.
Yes, there is a peribronchial distribution of
Yeah,
the nodules.
peribronchovascular.
Yes,
We call it perilymphatic, in which you see nodules along the fissures and in subpleural spaces. Okay,
nodular. Yeah, predominantly
okay,
the mid zone.
yeah, good. You did good. Okay, you just need to increase your confidence a little bit. Otherwise, your knowledge is sufficient to pass the exam. Okay, okay. Next candidate.
Hello.
Yeah, hi.
Hi.
This is your case, no history.
Okay. This is a frontal radiograph of a skeletally mature patient in which I can appreciate that thoracostomy sutures are in place. And apart from this, I can appreciate that there is a hazy opacity noted in the right upper mid zone. And which is showing well-defined inner medial margins, and the lateral margins are merging with the lateral chest wall that are suggestive of indistinct border or incomplete border sign. And apart from this, I can also appreciate a very faint nodule in this right load zone. And there is minimal blunting of the CP angles more on the left side. And okay, so I'm suspecting that this could be any metastatic process also, as I can appreciate two lesions, or it can be a benign lesion of the pleura, and this can be an infective nodule. And I would like to correlate with the history of the patient and further
No history
to
is required
characterize
in
this.
this. You need just this film to make the diagnosis.
Okay. Uh, mhm. Okay, here I could appreciate that there is some stunt also noted in the inferior aspect of the film, at the edge of the film. Likely it is some kind of esophageal stunt. And
Good,
if this is the case, then I'm suspecting these are the metastatic nodules of the esophageal malignancy.
good. But you're missing a major finding here.
Uh,
You made the
there is
diagnosis, but
migration of
missed
the
something.
esophageal. Yeah, there is migration of the esophageal stunt,
No, there is no
as it
migration.
is. Okay, or
Anything
maybe
else?
it is. Uh,
So what
okay,
do you
I
look at
would.
when you're suspecting metastasis?
Uh, for the primary, I would like to look at the CT images and.
This is the film that you require, nothing else.
Okay. Uh, okay. Uh, apart from this, mm, the apices are clear. There is some lucency here in the left upper zone, which is,
What are
I
your
guess,
review
just
areas?
the apices and the retrocardiac area. The retrocardiac area appears unremarkable. CP angles I have already commented upon. I would also like to look at the bones. Yeah, here I could appreciate that the overlying rib is also showing lytic destruction. Yes, yes. Okay.
Yes. Okay.
Mhm.
So you did good. You did really good. Okay.
Yeah,
But you don't have to
yeah,
miss such a major finding in the exam when you're
yeah,
suspecting
yeah.
metastasis. Otherwise, you picked up the
Okay.
stent and you made the diagnosis complete. Okay. So what will be your next
Yes.
step?
Next, I would proceed with the CT chest with IV contrast for further characterization and staging of the disease process with a 2-week wait pathway.
Only CT chest?
No, for staging, I would require a CT abdomen and pelvis as well.
Okay.
Yeah.
Okay. You did good. And I think you're done. Okay,
Thank
all
you.
the best.
Thank
Yeah.
you. Thank you.
Next candidate.
Yes, sir.
So this is your case. Young female with abdominal pain and vomiting.
Okay, should I take control?
Yes,
Okay, I have requested.
yes, go on.
Okay, I'm presented with axial non-contrast CT of a young age female patient presented with abdominal pain. I will first scroll from bottom to top and then I'll come in. Okay. As I'm going through, I can appreciate that there is moderate amount of free fluid noted with some dystrophic calcifications noted. In the abdomen, there are multiple gas-filled bowel loops, also fluid-filled bowel loops also noted. As I'm going further up, I was also able to appreciate multiple dystrophic calcifications in the region of the around the head of the pancreas, and few also seen within the gallbladder. I will go up till the last cut as per protocol. Okay, this is a CT chest abdomen. And now I will go again to the point of interest. So, okay, so in a young age female patient given ascites and multiple calcified calcified foci within the abdomen, diffusely scattered, and another high density structure also seen in the left adnexa. So these
What
calcified
is the possibility of this left
things,
adnexal lesion?
yeah, this could be a hemorrhagic cyst.
Or
Yeah, this could be an hemorrhagic cyst. Another possibility could be of a corpus luteal cyst, and third possibility if the
what if
patient has
this
any history of
calcified?
yeah, if it is peripheral, if it is calcified, then the other possibility could be of a dermoid, not a typical one, but because of the presence of peripheral calcification, or could be a could be a peritoneal inclusion cyst, or I haven't seen such peripheral calcified cysts, but these could be differentials.
What about a broad
So the
ligament
multiple
fibroid?
calcified. Yeah, broad ligament fibroid could be as well, yes. So the multiple calcified foci within the abdomen, diffusely scattered in ascites, are raising one differential possibility of the calcified lymph nodes. As these are diffusely scattered, I would like to see the post-contrast images for further
Yes, go for post
evaluation.
contrast. Yeah.
Yeah, sure. Okay, as I'm looking on the post-contrast image, I can further demonstrate the presence of multiple. Okay, I will re-look again this multiloculated area within the center of abdomen, whether it is a bowel loop or yeah, these appears to be clumped or clustered bowel loops with
Good.
some clustered bowel loops along the left side of the abdomen. And these are showing thick enhancing mucosa with some of the bowel loops also showing some kind of air trapped in between the folds. However, no, I cannot see any pneumatosis there as I'm going down. Uh, so
So
yeah,
do you
so
think this patient
overall,
has intestinal obstruction?
yes, this patient has intestinal obstruction. This
What is the
appears to be
cause?
as the bowel loops appears to be dilated, and as these bowel loops are clustered together in the left, so I'm suspecting any internal hernia going on there, or
Are the bowel loops thickened?
yeah, yeah, bowel loops appears to be thickened. And these could be secondary to any underlying inflammatory process or ongoing ischemic process. These are the two differential possibilities of
Do you
ongoing
see any
bowel wall
signs of
thickening.
ischemia?
Uh, okay, I'm trying to look
So what
out.
if you're suspecting ischemia? What are the structures you look at?
Yeah, I will review the vessels first for that.
Yes.
Okay, so I'm reviewing the vessels for that. First, as these are the small vowels, so I will give up attention to celiac and SMA. Celiac appears to be normal, now SMA. Okay, but I couldn't appreciate any obvious thrombus. Coronal and sagittal will be more helpful to comment. Okay, and I'm also will look into the portal vein as well. Okay, portal vein is also here well enhancing. No any thrombus noted
So
within
do
it.
you know any cause of bowel ischemia where the vessels appear to be normal on CT scan?
Yeah, the other possibility could be of in a young age female patient, in a young age female patient with so much ascites and these calcified these calcified structures which I was thinking of for the presence of any calcified lymphadenopathy there. So I was thinking in a line of some infective process like tuberculosis of previous any history of tuberculosis. Is there any history of previous tuberculosis?
Yes, there is a history of tuberculosis, but what is the cause of
So this,
intestinal obstruction here?
okay. So if there's a history of the previous tuberculosis, in the tuberculosis, the patient are prone to have any adhesions secondary to peritonitis. As I'm looking for the now peritoneal enhancement. Okay. I couldn't appreciate here any enhancement though. I will look into the ileocecal junction as well for any abnormal thickening.
Ileocecal junction is normal.
Okay, ileocecal junction is normal. So one thought which comes in my mind of these clustered bowel loops is internal hernia due to possible any secondary
There is no internal hernia.
internal hernia. Oh, okay, so the possibility could be of a closed loop obstruction secondary to any underlying adhesions to
It's
secondary
not
to
a closed
previous
loop obstruction.
infective process. Okay, I will look into the coronal images.
Yeah, look at the corner.
Okay,
Just stop right there.
um,
Just leave your
okay,
mouse.
I'm leaving.
You need just this image to make the diagnosis.
Okay, okay. Okay. So, yeah, okay. These are the only thing which comes in my mind is the presence of cluster of the bowel loops there.
So one cause you
So,
told was
yeah,
internal
for
hernia. That
me,
was okay. Okay.
yeah. Okay. In post tuberculosis case, the patients are usually it gets complicated secondary to any adhesions or we call it abdominal cocoon formation
Yes,
as the bowel
yes,
loops are.
yes. So the bowel loops
So
are
this patient,
clumped. They appear like a cocoon. Okay. But
yeah,
do you see any capsule here?
yeah, I can see. I can see these appears to be
Can you show me?
encapsulated and clumped.
Yeah. Can you show me the capsule?
Okay. Yeah, sure. This one,
Yeah, yeah,
this
yeah,
whole.
yeah, yeah. So this capsule was
Okay.
seen on the axial also.
Okay. Okay.
If you want to
Okay.
take a look, you can take a
Yeah.
look.
Yeah, I can take a look and further I will
Yeah.
complete my
So now do
management.
you
So
see the
this
capsule?
patient, yeah, I can see.
Yeah,
Okay.
good. What is the other name of cocoon?
Peritoneal sclerosing, mesenteritis or sclerosing, something like that.
Encapsulating peritoneal sclerosis.
Okay.
Okay.
Encapsulating peritoneal and
In which there are
okay.
clustered, encapsulated, fixed, dilated small bowel loops radiating from the center of the
Okay.
abdomen. Okay.
Okay. Okay.
And there are
Yeah.
loculated ascites and peritoneal calcifications. What is the most common
Yeah.
cause
Yeah.
of encapsulating peritoneal sclerosis or cocoon formation?
It is tuberculosis
Okay, so
in our
there
country.
are many
In
causes,
our
like it could be
yeah.
primary or idiopathic. In secondary causes, the
Yeah.
most common cause is peritoneal dialysis.
Okay. Okay.
Okay.
That the same thing is like of infective or to
Yes.
peritoneal
So
dialysis.
the most common secondary cause is peritoneal dialysis, then TB, sarcoidosis can also
Okay.
cause this, or
Okay.
peritonitis of bacterial origin, or peritoneal shunts like VP shunt or other shunts. Okay.
Okay. Okay. Okay.
Okay. What will you do
Thank
about the
you.
management?
Yeah. This patient further require as I'm suspecting the tuberculosis. I will scan and the chest CT was already done. I will scan through the whole stack of images to look any lung involvement, concomitant lung involvement. And I will, for now, I will immediately refer this patient to the surgical team as the bowel loops appears to be clumped. So there's a possibility of ischemia or or any perforation in this patient. The patient might require surgical consultation further and further whether the patient, as the patient, if the patient has any lung involvement, patient will be infective. So patient needs isolation, screening of close contacts, and confirmation of this sputum-AFib or peritoneal aspirate should be sent for CS.
Okay, good. You did good, but you took 9 minutes. Okay.
Okay.
And how will you differentiate it from the internal hernia? In internal hernia, there will be a swirl sign. Okay,
Okay.
swirling of vessels will be there. Okay.
Okay. Okay.
Okay. So you did good.
Thank
You made that final diagnosis of cocoon that very few people are able to make. Don't go anywhere, please. Just leave your mouse. Okay. Next candidate, do we have you?
Yes, doctor.
Okay. Good. So this is your case. You have to start from the first section. Okay.
Okay, I will request to control. Okay. I'm presented with axial non-contrast CT scan of the abdomen. From the first glance, I can see the stomach is seen distended with air fluid level.
Start again and tell me what you
Start
missed.
again. Okay.
This is an 80 years old female.
It's a
And they found
female
some
patient.
80 years
Yeah.
old female. They found some abnormality on the ultrasound and they sent her for CT scan.
Okay. From the first, I can see the left breast. There is
Breasts are normal. Just leave it.
okay. So I can appreciate there is a low density within the liver dome.
Yeah.
Okay. I will go to scan the rest of the liver down, and as I'm scrolling, I can see there is a bowel dilatation with stomach dilatation. I need to go further to check for the transition zone. As I'm scrolling down, yes, I can see here a segment of bowel within bowel, I think, like interception in the right side of the abdomen. However, I complete my scan till the end of the cut. Okay. This is the uterus. The rectum is also distended. I think there is ascending colon mass lesion complicated by an interception with secondary bowel obstruction, small bowel obstruction. However, I need, and there's a hypodense lesion within the liver. I think it's metastatic. I need to confirm it further in the post-contrast study and the coronal, if available.
Any other finding on the scan?
Sorry?
Any other finding on the scan?
Yeah, I can see the left kidney is atrophied
Okay.
with the cortical.
Okay, you can go to the contrast now.
Okay. This is a post-contrast study of the same
Which
patient.
phase?
This is arterial phase.
Yes.
I can appreciate there is multiple enhancing lesion studied within the liver parenchyma, likely metastatic in nature. For the pancreas, I can see any abnormal mass lesion within. However, I will go further to scan the lesion I checked in the plain study.
So what kind of metastases are these?
This is hypervascular metastasis.
Yes. So what are the causes of hypervascular metastasis?
Hypervascular metastasis could be secondary to a melanoma, or could be secondary to pancreatic lesion,
Like what?
neuroendocrine lesion like insulinoma or gastrinoma.
And other
Um,
causes?
Other causes, renal cell carcinoma.
Good.
Okay. And if young patient, it will be choriocarcinoma. I am dealing with a metastatic hypervascular liver lesion secondary to ascending colon mass lesion. I need to confirm the position of the lesion adequately in coronal study, if
Yes, you
available.
can see the coronal.
Okay. It is a single image.
Yeah, I think it is a single image.
Yeah.
So go back to the axial contrast.
Okay. I will go to the portovenous phase.
Yeah, if you want to go to portal venous phase, it's okay.
Yeah. For the portovenous phase, previously mentioned liver lesion show wash out in the portovenous phase.
So you told me a few causes of hypervascular metastasis in liver. Have you looked for all the causes?
I am checking the kidneys as well for any abnormal enhancing lesions.
Kidneys are
I
okay.
think
Pancreas is
kidneys.
normal.
Yeah. The pancreas is normal as well. Um,
There is no history
so
of melanoma.
So the remaining will be adenocarcinoma of the colon or
Is it hypervascular?
adenocarcinoma, not hypervascular. The other is carcinoid tumor also as well of the bowel. And as I see here, I see some, this is bowel thickening with like stranding surrounding. I am not sure this is tethering of the bowel or no.
See the arterial phase again.
Okay.
Go to the terminal ileum.
Okay.
Yeah, stop there.
Yeah. Yes.
Go one section up, 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 up. Stop there.
Yeah.
What do you see?
This lesion
Yeah.
is
What is the enhancement
hypervascular.
pattern? Yeah.
It
Where is it
could be
arising from?
from the terminal ileum, I think, or the iliac outlook. I need to appreciate.
Yeah.
Yeah, it's within the terminal ileum.
And the
So
surrounding?
it's surrounding by stranding of the mesentery. So this is, I think, terminal ileum carcinoid.
With?
With complicated by bowel obstruction and intersusception and metastatic lesion to the liver as well.
Okay.
In my routine practice, I will check the bone window as well. If any metastatic bony lesion, I will refer the patient for the GIT oncology team, and I will complete my metastatic workup for the chest and the abdomen and pelvis.
Okay, and what is the next best investigation to prove your diagnosis?
I can ask for a nuclear scan for carcinoid.
Which nuclear scan?
Yeah, it's 68 dotatate.
Gallium 68.8.
Yes,
Okay,
it is
so if the
specific.
patient is having hypervascular metastasis from a carcinoid,
Yes,
is the patient at risk of developing any syndrome?
hypervascular. Yes, the carcinoid syndrome.
Yeah. What is the carcinoid syndrome?
If the patient complaining from diarrhea, I think with the hypervascular metastasis, I can't recall the rest of the syndrome.
Okay, so
But
flushing, diarrhea, bronchospasm, and right
yeah,
heart
yeah,
valvular disease. And
yes.
it is due to the release of
I think this is more from the histamine or
serotonin.
serotonin. Yes.
Okay, and if there is carcinoid syndrome, what will be the medical management?
The medical management? No, I can't recall.
Okay, it is octreotide only.
Okay.
Okay.
Yeah. Okay.
Yeah. So you did good, but I had to like prompt you a little bit. Okay. Otherwise you did good. Okay.
Okay. Thank
Do
you.
we have the next candidate?
Yes, doctor, I'm here.
Okay. So this is your case, and there is swelling around right hip. Just
Okay,
tell me
here
what you see.
I
Yeah.
will external control.
Yeah.
Okay, so here there is a swelling seen surrounding the right hip where it appear heterogeneous densities appear rounded grape-like appearance with multiple heterogeneous densities, low density, intermediate, and high densities, with no affection of the underlying bones. This is likely to be a synovial disease.
You're going straight to the diagnosis?
Sorry?
You're going straight to the diagnosis without describing the lesion.
Yeah, I describe the lesion as the lesion is seen very articular with multiple cystic areas and giving grape-like appearance with multiple differential intensities, appear low signal and intermediate signal with high signal intensities. It appear encapsulated and multiloculated with no
What is the
affection of
cause
the
of these different intensities on MRI?
um, uh, I
Won't you like
totally.
to take a look at any other sequence?
Yeah, I would like to also look at the contrast enhancement sequences.
Look at the axial first,
And okay,
axial T2.
okay. This is axial T2, and I can see there is a shading sign seen within some of the cases with of the cysts, with also another cyst shows fluid level.
What kind of fluid levels are these?
This is likely
What is
to
the
be
sediment like? What is the sediment there?
sediment is dark.
So what does that mean?
This is likely to be maybe blood.
Blood
And
so dark?
so not yeah, it's so dark here. This may be calcium
Yeah, so
also, calcification, and there is also multiple other cystic areas shows high density as well. Yes.
so you can look at the contrast now.
Okay.
So now does it look like a synovial sarcoma?
No.
So what does it look like then?
It shows peripheral enhancement with also
Peripheral and
enhancing of
septal
the
enhancement, yeah.
peripheral and septal enhancement, yes, with no enhancing of the cystic areas. So for this lesion was also containing calcification. This may be I would like also to check if there is any previous radiographs to see to check the radiograph if possible.
First of all, you tell me what these sediments are. You told me these are calcium, but calcium or milk of calcium?
Is this milk of calcium or maybe fibrosis? Also, it gives a triple sign.
So in which condition where you see a soft tissue mass in periarticular region with fluid calcium
I'm thinking
levels?
about fibrocystocyte.
MFH?
Yeah.
No, it is not that.
Okay. So this may be also
A soft tissue mass, multiloculated
Tumoral,
with fluid calcium
tumor,
levels. Yeah. You were saying
maybe
something?
tumoral calcinosis. I think this is the tumoral calcinosis seen surrounding the joint, involving soft tissue and the muscle.
Okay, good.
Yeah.
So what is the cause of tumoral calcinosis?
This may be idiopathic or renal disease.
Okay, it is either familial metabolic defect of phosphate regulation, in which there is hyperphosphatemia,
Yeah.
or it is secondary hyperparathyroidism. Okay.
Yes.
Okay.
Yeah.
Good. We make
Okay.
the diagnosis
Thank
finally.
you.
Okay, but I had to prompt you a little bit. Otherwise, you did good. Okay.
Mm.
So all the best.